And as everyone is joining us, I'll just remind everyone that if you have questions for Dr. Castro, please put them in the Q&A function of Zoom. That's where we'll be monitoring questions that are coming in. But if you want to say hi to us or to each other, you can do that in the chat. And but again, if you have any questions, make sure they go in the Q&A and not in the chat. That's where we'll be monitoring.
Right
And I
now, people
just,
in the chat are just saying where they're coming from, which is always great. Yeah,
yeah.
put in where you are today. We have people from Vermont, Vienna, but I think it's Vienne, Virginia, I think. We have Saskatchewan, Knoxville, Tennessee, Vermont, New Mexico, Grand Rapids. Hi, Sue. I haven't seen Sue in a while. Hollister, California,
Oh, wow.
Atlanta, Nova Scotia, California, Buenos Aires, Houston, Arizona, Augusta, Belgium. Fantastic. Perth, Australia. Oh my goodness. It must be something like 3 in the morning
It's
there.
it's late there.
Kentucky, New Jersey, British Columbia.
Oh, Robin says it's 2 a.m. where she is in Perth.
Oh, wow. Cal California, Alberta, Toronto, from France. Hi, Sylvie.
All right.
Yes.
We could probably get started. It is the top of the hour.
Okay.
Um, and I don't know, June, if you wanted to start recording before I do the welcome.
Yes, I will.
Okay.
It's paused right now, or is it going? It says it's going.
Oh, it
Do
is
you?
recording. Okay, good.
Okay.
Yeah. Okay,
Start
great.
sharing.
Yes. Well, just real quick, hello everyone, and welcome to FSHD University. I'm Beth Johnson. I'm here with my colleagues, Miss June Kinoshita, our Senior Director of Education and Research, and our new Director of Education and our host of FSHD University going forward, Miss Ashley Ferreira. Ashley.
Thanks, Beth, so much. And hello, everyone. I'm really excited to start sharing these monthly FSHD University hours with you. I really look forward to hearing from our presenters and learning about all of these topics with you. And of course, on behalf of the FSHD Society, we'd like to welcome you to our February FSHD University Anesthesia during surgery for people with FSHD. People with FSHD are often warned to be cautious with anesthesia, but there isn't a great deal of medical guidance on what this means in practice. So today we are excited to have Dr. Castro de Oliveira with us as our presenter. Dr. Castro is a board certified anesthesiologist and director of the orthopedic anesthesia service at Mass General Hospital. She has participated in a number of scapular surgery procedures for patients with FSHD, and today she will explain surgical anesthesia and review considerations for individuals with neuromuscular conditions with FSHD in particular. Please join me in welcoming Dr. Castro. Dr. Castro.
Thank you. Thank you very much for this kind introduction. Can I start sharing my screen?
Yes.
Yes, you can.
Very good.
I'm going to.
Let's see. Can everyone see my slides?
Yes.
All right. Very good. So I'm Bruna Castro de Oliveira. I'm an anesthesiologist here at Mass General. I've been here for the last 10 years. And I spend most of my time in orthopedic surgery, doing anesthesia for patients with all sorts of orthopedic problems. And the way I got connected to this webinar was through one of our shoulder surgeons. We do a lot of the thoracoscapular fusions together. So I kind of like based the lecture on this procedure, but everything that I say here can be applied to a lot of different anesthetics, like sedations, general anesthetics. I'm just going to go over the main things, and I selected a few questions that some of you sent at the end, so we can go over some general questions that people may have that will include a lot of the important things that we need to cover for patients with FSHD coming for anesthesia. The other thing I want to say up front is that every anesthetic is tailored to the patients and the procedures. So here's going to be just a general concept of what we look for when we pre-op a patient, but every patient is pre-opt as one patient and not everything can be generalized. Okay, and I'll be happy to answer additional questions towards the end. Okay. All right, so you guys probably know a lot more about FSHD than me.
Oh, Dr. Castro, I think you might be in presenter mode. I think we're seeing like 2 slides. If you can go into slideshow.
How do I get out of that?
I'm not sure.
I see what you mean. Because I have 2 screens here. One of them is on, let me see.
Oh, it says hide presenter view.
I'll try again. Interesting. I've never had this problem before.
Can you go up to the top, hide presenter view? Maybe click on that. Did you see that? Oh. No, you before when you clicked on the 3 dots.
Oh,
And then it opens a menu there, hide presenter view. Maybe that. That's not the slideshow view though.
interesting.
That works. That's better than the presenter view. I think this is fine.
This is better. Let me
The
just.
slides are bigger for sure.
There we go.
Okay.
Okay,
This is better?
that's better. Yes.
Yeah, that's not ideal, but I guess we can go with this. I don't know how to make it.
What if you go to resume slideshow? Does that?
Resume slideshow. Yeah, that's what I'm looking on. No, it's not going anywhere.
Okay.
Interesting. Oh, it's going on my other screen. Huh. Not sure how to fix it.
Audience says it looks great. So why don't we just?
Can we just continue on with
Let's
it?
just continue with this.
Not ideal, but I guess it's not going to be much better than that. So as you all know, FSHD is a genetic condition that affects mostly muscles on the face, shoulders, trunk, upper arms, upper extremities. Why is it important to be careful with patients with those conditions in anesthesia? As you probably know already, the muscle weakness and the sensitivity to some of the anesthetics can influence how we provide anesthesia to patients with those conditions. And here on the picture are just some of the areas that can be affected by the dystrophy. So as I mentioned, I do a lot of orthopedic surgery, and the majority of patients I see in the operating room with this condition are coming in for thoracoscapular fusions. And it basically helps stabilize your scapula to the rib cage. We just fuse the scapula to the rib cage for this kind of procedure, provide general anesthesia for the patients, and most patients do pretty well after the procedure. It helps improve shoulder stability, helps with the pain, and helps with the function as well. And obviously, it's a sort of a moderate sized procedure, and the anesthesia just helps the patients get comfortable and get through this procedure safely. So here, just diving into some of the anesthetic considerations and implications for patients with FSHD. I'm going to go by systems just to make it a little easier for us to discuss. So respiratory considerations, some of the patients with diseases that are in a later stage can have restrictive lung disease, and that can be concerning for hypoventilation, meaning not being able to take deep breaths or ventilate during the procedure. That's especially concerning when we give sedation or pain medications, and can lead to pulmonary complications, especially if you're not being closely watched by an anesthesiologist or a PACU pre-op nurse. Some of the patients can have sleep disorder, meaning OSA, which is sleep apnea, and central apnea. And sometimes, not all the patients, we usually, when we pre-op the patients, we refer back to either their PCP or if they have advanced lung disease for their pulmonologist to get pulmonary function tests pre-op. Again, not every patient is going to need it unless you're in advanced stage of the disease. Okay, cardiac considerations, arrhythmias and cardiomyopathy can be a concern. Most patients will have an EKG, depending on what cardiac conditions the patients have. We might need an echo, a TTE, to further evaluate. Again, doesn't apply to every patient unless the patient has cardiomyopathy or other problems that can be concerning cardiac-wise. Neuromuscular considerations, those are the ones that are the most common. Patients can have increased sensitivity to the anesthetics. There is one particular class of anesthetics that we worry about the most, which are the neuromuscular blockades, especially succinylcholine. And I'm going to talk a little bit more about it as we progress in the lecture. Okay, even with the neuromuscular blockers are divided in depolarizing, non-depolarizing. Succinylcholine is a depolarizing one, and should be avoided in every patient with any muscular dystrophy. And the depolarizing one, the non-depolarizing ones, which we usually use, are rocuronium, vicuronium. Those can be used. The one thing that we have to be careful with is the prolonged muscular weakness. And I'll tell you how we make sure that the patients that need to receive it for the anesthesia recover well after without a problem. Pre-op evaluation. So as I mentioned in the previous slide, we usually try to get a comprehensive multidisciplinary pre-op assessment that involves us. And if necessary, we get the input of neurology, pulmonology, and cardiology, depending on what stage of the disease the patient is in. Okay, and that's, as I mentioned, based on every particular patient, like it's not generalized. Pulmonary optimization, baseline pulmonary function tests, if necessary. Incentive spirometry is something that we do routinely for most patients getting general anesthesia, especially if they're deconditioned, if they're going to stay in the hospital for a long time. It's just like a little like device that we have patients breathe through to increase the pulmonary capacity, avoid atelectasis during the peri-op time the patient spend with us. And non-invasive ventilation, we will use as needed if the patients require. Those are usually used if the patients are already having trouble breathing before the procedure. If they have general anesthesia or even a sedation, they can be extubated to what we call a non-invasive ventilation, which is basically a face mask that will help opening up your lungs after the procedure. And peri-op respiratory muscle training that can be done with a physical therapist. Cardiac assessment, as I mentioned before, EKG is pretty standard. Most patients will have an EKG pre-op, unless you're like a healthy 20-something-year-old patient coming in for a simple procedure. That's not necessary, obviously, but most patients coming in with FSHD will have a baseline EKG. Depending on their cardiac condition, it needs to be within 6 months. If the patient has been stable, probably doesn't need to be repeated. Okay, and the EKG, the echo will be necessary depending on what condition the patient has. If the patient has a cardiomyopathy or any other sort of cardiac problem that will need an echo. This patient will probably be followed by a cardiologist. We will work with their cardiologist and their pulmonologist and other specialists that the patients are seeing to make sure that the patient is optimized for surgery. Medication considerations in the peri-op area, we are very attentive to sedating medications, especially because of the risk of respiratory depression. We do that for every patient, but patients that are more sensitive to it, we definitely pay extra attention and give it if necessary. Okay. other medications that the patients can be in that can impact the anesthetic is steroids. And that's because if the patient is on a high dose of steroids, we usually try to make sure that they took it the day of surgery, their baseline dose. And if they're coming in for a very complex procedure, or if they are on a very high dose, those patients will need an extra, what we call a stress dose of steroid, just for their suprarenal glands to be able to work under extra stress. Imaging is based on the patient. Obviously, not every patient is going to need a CT or MRI of the thoracic cavity before coming for the procedure. It will depend. If they have very compromised lungs from the disease, then we'll evaluate if imaging would be necessary. Anesthetic plan. General versus regional considerations. General anesthesia. So for patients with FSHD, airway concerns. General anesthesia, meaning that the patient is going to be at a stage of sleep where an anesthesiologist or an anesthetist is going to have to help them breathe for them. So that means endotracheal intubation or placing of an LMA, which is like a mask that mimics an airway. That's also considered general anesthesia, okay? For those patients, since they have weak pharyngeal muscles, it can be tricky to intubate and more likely to extubate. So we're extra careful. We have a lot of like different tools that we use for intubation to make it easy and simple. And for the extubation portion, a few things that we make sure with the sensitivity to muscle relaxation, we always make sure that the patients are fully reversed. And there was a question about Sugemadex that I thought was excellent on the questions that one of you guys sent to me. And Sugemadex is a great drug that helps us make sure that all the muscle relaxation that has been given to the patient is out of the system or no longer working. So the way we test it is we have a little machine that is called a train of 4 that we test for muscle function on every single patient that we give general anesthesia. And we make sure that the muscle function is fully back to normal. And it's quantitative, so it can give us like how strong the patient is. So for patients who come in with already like baseline muscle weakness, we test it in the beginning, right after you go to sleep, because it's a little painful, and right before you wake up, just to make sure that you're back to your baseline, okay, before we extubate. Induction agents, there was a question about propofol, if it's safe. It's very safe, and it's actually the preferred drug. And that's what we usually use for 99% of our anesthesia inductions. And opioids are equally safe. They just have to be used with caution, not to overdose. But usually for surgical pain, even if we do a multimodal that we try to do for most patients, a small dose of opioid would still be needed, but we judge based on the type of surgery and what the patient can tolerate, okay? Neuromuscular blockade, I feel like I talked about it a lot already. Succinylcholine, definitely prohibited for patients with any kind of muscle dystrophy, because it can cause rhabdomyolysis, which is like destroying the muscles, because it causes a very important muscle contraction when it goes in, and it can release potassium, causing hyperkalemia that can interfere with your heart function and give you arrhythmias. That's why succinylcholine is a no-no for patients with muscle dystrophies. The other muscle relaxants are the non-depolarizing ones. Rocuronium and vacuronium are the ones we have available in most hospitals here. And as I mentioned, it is safe to use. It has to be monitored before extubation, just to make sure that your muscle function is back to normal, okay? Regional anesthesia is great. It can be applied to a range of different surgeries. And it helps a lot because it decreases the amount of opioid we give to patients because it takes away the pain. There are a few ways we can give regional anesthesia. We can do what we call a single shot block, where we give you one injection of local anesthetic that can last sometimes for 16 to 24 hours. And depending on what kind of surgery the patient is having, there's also an option to place a catheter that can stay in place for a few days. In the OR, just a little general idea of what happens when we go into the operating room. So for patients with muscle dystrophy, when we induce, this is general anesthesia that we're talking about here, ventilation strategies, we try to be as gentle as possible in the tidal volumes. We do what we call low tidal volumes, which is like the amount of air we give when we are ventilating you through the machine or hand ventilating, and a lung protective ventilation. But that's the standard that we would do for every patient. We're definitely extra careful if the patient has any limitations or sensitivity. Monitoring, as I mentioned before, the train of 4 is the neuromuscular monitoring. There, it's a standard that we use for every patient, at least here in Mass General. I believe everywhere else should be the same. Temperature monitoring is one of the 5 ASA monitors is temperature, so it's required to be monitored for every anesthetic that we give. And on top of monitoring the temperature, given that the ORs are like extremely cold, we also have like blankets that actively warm the patients up. Once you go to sleep, we put those on the patients to make sure that they are not hypothermic during the procedure. Positioning, I believe there was a question about positioning. That's an excellent question. Both the anesthesiologist and the circulating nurse and the surgeon are involved in position for every procedure that we do. And we are extremely careful, especially with patients with limitations. We try to pad every area, especially where the nerves are the most superficial, and that can be a problem, like the ulnar nerve here, and everything else. We are very due diligent with positioning and padding in the operating room. If the patient is getting a sedation or is coming in for a procedure where they're going to be supine, one of the things that we usually do right before we go to sleep is to have the patient position themselves and ask them about any kind of range of motion limitation. Have they show us like how much you can move before we put you to sleep and give you muscle relaxation, because that makes you a lot easier to move. So we're mindful of like how much you can move and try to like just position you before the procedure to make sure that it's the most comfortable position possible. For some procedures, that's not possible. For example, for the thoracoscapular fusion, sometimes we have the patient's position lateral after you go under general anesthesia. Sometimes you go on your belly. So that's when we have to be extra careful when we position the patients, and we make sure that the range of motion is adequate after the final position is done. And it's, as I mentioned, it's a multidisciplinary approach that we do for positioning as well. Surgeon, circulating nurse, and anesthesiologist, to make sure that everyone is aware of the patient position and is happy with it. Postoperative considerations and extubation planning. Most patients that we see coming in for surgery are in good pulmonary function condition. The ones that are not, we try to be mindful of a few things. Pain, pain is one of them. We try to usually minimize opioids for patients that can have respiratory compromise after procedures. So we try to do what we call a multimodal approach. We give Tylenol, sometimes NSAIDs if the surgery is okay, if it's not a lot of blood loss, if the surgeon is okay with NSAIDs. Gabapentin, especially if the patient is already on gabapentin, and regional anesthesia is a great tool to help avoid opioids. For certain procedures, nerve blocks are not feasible. Some of the procedures we can't do nerve blocks. For instance, the thoracoscapular fusions, giving the area that they work is a little bit on the back. It depends on the surgeon preference if we can give nerve blocks or not. And we also we can do based on the patient. If the patient is really, really compromised and cannot tolerate opioids at all, then we'll try to come up with a plan where we can minimize opioids as much as we can. Okay, and that's all to prevent respiratory depression. That being said, we try to strike a good balance between being very mindful of the respiratory status of the patient and also of their pain. We definitely don't want anyone in excruciating pain. So there's a balance there. That can be achieved with like a good anesthesia plan and a surgeon that is on board with the plan. And obviously, our post-op recovery room nurses that do an amazing job helping us manage the patient's pain and the vacuum and making sure that they're breathing and comfortable and safe. Monitoring, depending on how compromised the patient is in terms of respiratory, we can escalate for an ICU stay. Very, very rare that it happens unless there is serious respiratory compromise. Most patients do well just going to the recovery room and being close monitored by the anesthesiologist who's in the area and by the PACU nurses that are readily available. If the patient needs and is in respiratory compromise, we can do what we call like arterial blood glasses to measure the oxygenation in the blood and pulmonary function tests for assessment. Again, that's very rare, but it's always in our backup plans. So summary, so we can focus a little bit on questions. FSHD patients have increased sensitivity for anesthesia, requiring a very careful pre-op planning. I wouldn't say they're at increased risk, but definitely needs attention. Respiratory compromise is one of the major concerns. Optimize pre-op and plan for careful extubation, especially on patients who have respiratory compromise prior to the surgery, is very important. Succinylcholine, definitely contraindicated for any muscular dystrophy. And other types of neuromuscular blockers require very close monitoring. And we need to make sure that the patients are back to their baselines before we extubate. Regional anesthesia is a great tool to enhance recovery and reduce the amount of opioids used. And if necessary, post-op respiratory support with what I mentioned before, the incentive spirometry, and also non-invasive ventilation if necessary. I have a few questions here that I selected, and then we can go over other questions. Just need to sit further before we do that. So one of the questions, is propofol safe? Is propofol safe anesthesia for people with FSHD? Very, very safe. Propofol is, in general, a very safe drug, and it's widely used for different kinds of procedure. We use it for sedations, we use it for general anesthesia. The only contraindication that I can think of for propofol in general is allergy, and it's very, very rare. Other than that, no contraindications for patients with FSHD. A very safe drug when used in the right setting in a hospital when you're assisted by an anesthesiologist or an anesthetist. What medications are contraindicated in anesthesia besides succinylcholine? Succinylcholine is the only drug that is definitely contraindicated. The other ones, as I mentioned during the lecture, are more sensitivities that we have to be aware of, not a hard stop for any other drugs other than succinylcholine. This is a great question. Is malignant hyperthermia a concern in this patient population? Sorry. There is a general idea that MH, malignant hyperthermia, is common in patients with muscular dystrophy. It's not the case. It is not a concern. Those are two very different entities and they do not cross over. Have you used Sugemadex, Precedex, or any of the newer meds successfully in this patient population? Yes. Any issues? No issues. Outside of likely needing a smaller dose of paralytics, do you find issues with this class of drug? Excellent question. And I think I addressed it during the lecture. Smaller dose, definitely. With the use of Sugemadex for reversal of neuromuscular blockade, we have had a pretty great success of using those medications for patients with muscle dystrophy. We can do general anesthesia without neuromuscular blockade, but for certain surgeries, the surgeons do need the patients to be relaxed. That can definitely be avoided, but for certain surgery, it can. If we do need to use non-depolarizing neuromuscular blockade, it is extremely safe to use, as long as it is reversed at the end and the neuromuscular function is measured before extubation. What are your thoughts or concerns on regional nerve blocks for FSHD population, especially related to already weakened muscles, spinal rapid or anesthesia concerns? Another great question. So I also do nerve blocks. I'm part of the regional team. And one of the things that we assess before we give a patient a nerve block is if the patient has a permanent nerve damage or weakness in the limb that we're gonna anesthetize. Most of the time, we try to avoid giving regional anesthesia unless very necessary. Let's say the patient has other conditions that would be concerning for the patient to go under general anesthesia. That's one time that we would consider giving regional anesthetic to someone that we have concerns for, like nerve impairment, numbness, or not being able to use the limb. So that's assessed based on the patient, on the surgery, and on the bigger picture. Patients with FSHD in particular, we use the same rule that we would use for other patients, but always keeping in mind that this patient population is more sensitive to muscle weakness and nerve damaging, depending on what kind of procedure they're having, what kind of block they're having. So we're very mindful of offering blocks, meaning regional anesthetics for this patient population. Same applies to spinal and epidurals. Is positioning a concern, especially with any restrictive range of motion issues? Any helpful tips or concerns? As I mentioned during the lecture, position is definitely a concern. Patient is coming in for a procedure. We definitely do not want to cause any harm by positioning the patient in a position that is not comfortable for them. So things that we can do, as I mentioned prior, we can have you position yourself on the bed if it's a surgery where you're going to be staying on that position. If it's a surgery where we have to move you after you go to sleep, we usually assess what the range of motion is, in particular like limbs or neck, to make sure that we don't go beyond that when you're positioned for this surgery. I'm happy to answer other questions that people may have, but that's what I have for today.
Wow, great. Thank you so much. That was such a great presentation. And for people in the audience, this will be put on our YouTube channel, so you can refer to it later. So let's dive into some other questions. Rick asks if one has dyspnea, I guess, which I guess, difficulty breathing,
Mhm.
should the anesthesiologist be alerted before surgery?
Sorry, I couldn't hear the last part.
Oh,
Say
he
that
wanted to
again.
know if the anesthesiologist should be alerted about it before
If they
surgery.
have dyspnea, definitely. Few things, like dyspnea is a very general concept. It can be caused by many different things. It can be cardiac related, it can be pulmonary related, so definitely important to know what's the etiology of the dyspnea. So the proper workup can be done prior to the surgery. If it's cardiac related, then have a cardiac workup, usually led by a cardiologist or a PCP. If it's pulmonary related, then by a pulmonologist if necessary.
Mhm. Okay, thank you. There are a number of questions relating to whether the recommendations you're giving are very specific to this type of surgery or are generally applicable.
Generally applicable for any general anesthetic, sedation as well, especially the pre-op assessment.
Okay. What about a procedure like dental surgery, wisdom teeth being pulled? Because they don't
Yeah,
generally.
depends.
Yeah.
Some of them are done in the office
Mhm.
and some of them are done in the operating room. Usually surgeons don't bring patients to wisdom teeth removal to the operating room unless they can't stay still, patients who have developmental delay or patients who are extremely sick to have any kind of anesthesia or sedation in the office. So those are taken care of by us here in the operating room, but those are like patients that really need extra attention and would not do well in an office-based procedure. In the office, I don't do those procedures myself, but nothing that they give there is harmful per se to the patients that can cause any harm depending on how advanced the condition of the patient is. Like here we're talking about muscle dystrophy. Nothing, like they don't give general anesthetics for those procedures in an off space. So the only medication that, as we mentioned, would be contraindicated would be succinylcholine. That's something that is not given for a sedation in an office. Everything else that they give should be safe, but has to be tailored to someone who's sensitive to anesthesia. Local anesthetics are safe. That's the main thing that they use.
Yeah, great. We have a question from someone who might be getting surgery and was wondering if they should have preoperative tests done for things like, you know, cardiac function, respiratory, other things in preparation.
That's a general question that would be hard to answer without pre-oping the patient and seeing the patient. As I mentioned during the lecture, it will be evaluated by the anesthesiologist that is going to be taking care of the patient, or the institution here. We have like a service that will pre-op every patient that comes beforehand, and then the anesthesiologist the day before that does their pre-op assessment. It will really be based on your past medical history, how advanced your disease is and your condition is, and other factors. So I cannot like
Yeah, fair enough.
yeah, can't be very specific on what is needed. We need information on age, past medical history, what anesthetics have you been through before, anything acute that is happening prior to the procedure, what procedure. So all those things are taken into consideration, and at least a basic pre-op assessment should be done, and then additional things like tests and being evaluated by a specialist should be based on all those things that I mentioned before, and it's very patient specific.
Here's one from someone wondering if you have been under an anesthetic before. I guess if you've had general
Myself,
anesthesia before, does that increase risk for future procedures?
so if having an anesthetic before increases the risk of
for
having a procedure again?
future anesthesia? Like,
No, no, it should not. Doesn't like everything that we do in the operating room with an anesthetic, just generally speaking, it's very short acting, everything that we give. Unless we're giving you a catheter, everything that is giving in the operating room, like the goal is to get you comfortable for the procedure and waking up right after the procedure. So only like pain medications and a few other medications will stay in the patient's systems, but that shouldn't be longer than like a couple of days. And then it should not interfere with other anesthetics unless something out of the ordinary happens, which is not the usual. Like having an anesthetic is not a risk factor for having an anesthetic after, if that's the question.
okay.
Did that answer the question?
Yeah, I think so, probably. And here's a question from someone who said her neurologist had recommended avoiding Ringer's lactate solution for all procedures. Do you know why that would be?
I think I saw this question on the email you had sent me.
Mhm.
No, I cannot. Yeah, give you a good explanation for this recommendation. Like Ringer lactate is a fluid, for people who don't know. It's a kind of, it's a type of fluid that we use in the operating room. It's the most standard fluid solution that we use for every patient. The only patient that I can like maybe concerns for potassium, they do have electrolytes in those fluids, most of them do. The most common ones that we use are Ringer lactates and normal saline. Normal saline is like saline, only has sodium and chloride. Ringer lactates will have a very small, very, very, very small concentration of other electrolytes to a point that it would not interfere with any muscle function, cardiac function, or renal function. Sometimes for patients with very, very advanced renal disease, we try to avoid extra electrolytes because it can accumulate in patients with renal dysfunction. But other than that, unless you're having the other situation that I can think of is neurosurgery. When we're having brain surgery, we try to avoid Ringer lactate, not a contraindication, but no, that's we can
Okay.
use Ringer on most patients.
Right. Okay. Thank you.
Especially for short procedures, the dose that we give is very, very, very low.
So this person might have had some other condition that made their
Maybe.
Yeah. So we have a couple questions here. I think I shared with you in advance our medical alert card. And it states, that there should be, there are precautions around use of anesthesia. Is that enough information for a first responder to know what to do or what not to do?
Quick look I gave, yes, for first responder, it should be very helpful and enough information for what they would be able to do. Yes.
Okay. And there were some check boxes, but those are really meant for to be individualized. So I think I'd say probably review it with your primary care physician about which of those boxes should be checked off, I think. And several people, I think, have wondered, is there maybe a checklist you can give us of what to go over with an anesthesiologist before surgery?
I would say the main thing for us, I'm not even going to talk about questions, is whenever you're getting surgery, you get a list of to-dos, like things that you should do before surgery. And those are very important to follow. And I understand that it's a very stressful time to have surgery. And what we see a lot is like, oh, I forgot to take this, or I took this and I shouldn't have in terms of medication. So instead of giving you a list of questions, I can give you some important things to ask. But I think the main thing is following the pre-op guidelines that the surgeon's office are gonna send you in terms of like what medications to take or not to take, when to eat the last time, keep up with the fluids as much as you can the night before, and the morning off until up to 2 hours in clear liquids. Those are the most important things that the patients can do to make sure that they come in and they're safe for the anesthetic, other than the pre-op consult with the anesthesia team prior to the procedure. Reading the instructions is crucial. I know there's a lot of information there. I've been through it myself. Even not like knowing what to look for, I was like, wow, this is overwhelming. It's a lot of information here. But it's very important to follow all the rules in terms of medications, what we call the NPO status, which is like the last time you had anything to eat or drink. Those are very, very important. Questions to ask. Most anesthesiologists, when you come in, and I'm based here on my practice, are gonna come in and they're gonna ask you a few standard questions, just to have a general idea of your current health, if anything has drastically changed since the last time you had an anesthetic, or you had a pre-op assessment. The most important things would be, I don't know what kind of anesthetic is gonna be given, from the patient perspective, what to expect for recovery. Are you gonna stay in the hospital? Are you gonna go home the same day? What's the plan for pain? And also, I'm sure all the patients here are very knowledgeable about their condition, just making sure you tell everybody about it. And make sure you know that everyone knows that you cannot receive succinylcholine. I think that would be the main thing for patients with FSHD. But again, everyone who's going to be taking care of you for an anesthetic should know. There is no harm in reminding everybody. And also like the positioning, motion restriction is something that you should inform your anesthesiologist. That's mostly what I can think of being on the other side, in terms of things that you should know, do, or ask.
Great. And since you mentioned succinylcholine a number of times, just for context, people are wondering, is that actually widely used, so that, you know, there's a risk someone didn't know you have FSHD would use it, or is it
It is definitely available and we use for certain circumstances. It is used a little less these days. So the use of succinylcholine, we use succinylcholine when we need to intubate a patient with what we call a rapid sequence intubation, or if it's going to be a very short procedure and we need a general anesthetic with a breathing tube. It's helpful because it has a very short onset and offset. So it's easy for you to intubate the patient quickly if they need to be intubated quickly, and it also wears off very quickly. So there is definitely a scenario where it is very useful. That being said, with Sugammadex being available, and we have other drugs that we can use to intubate patients too, everything that we give everywhere, every medicine, depending on the dose, all of them will have side effects. We just have to tailor the anesthetic for the patient, and they all have their uses. So succinylcholine definitely is available, and it is helpful in certain scenarios. But for patients with muscular dystrophy, we avoid it, obviously, and we can use other medications like rocuronium combined with Sugammadex that we can achieve a very similar short intubation time and short extubation time, and other drugs that are not muscle relaxants like remifentanil that we can use that will make the patient relaxed for the intubation and that they will go away very quickly and they have no impact on muscle dystrophy patients. But it is available. It's in the ORs. Usually when patients come in that have a contraindication for something, we sometimes ask for some of the medications to be removed from the room just to avoid any sort of like problem, or we put a tape over it. We try to make sure that everyone knows that this is a no-no for certain drugs that can cause serious harm to patients.
So what happens in a scenario where someone has come in with an emergency? They've been in a car accident or something. They're unconscious and can't tell anyone they have FSHD. What are the risks to that patient?
A great question. It depends. If they come in intubated already from the scene, the risks would be probably just ventilation, and we will be very careful with every patient coming in for an accident, like we try to be as thorough as possible, given the emergency scenario. We usually have a lot of people around, making sure that everything is safe and done adequately for the patients. If the patient is not intubated, so that's the one circumstance that succinylcholine could be an agent that we use. If we don't know anything, most of us, we use rocuronium, because that would be a safer option, as I mentioned before, especially if you don't know anything about the patient. Can succinylcholine be used in a circumstance where we don't know anything? I can't say 100% of the time no, but most of the time rocuronium would be the drug of choice, knowing that succinylcholine can have contraindications for a certain patient population. It's rare that we have a patient that comes in that has no information at all in the system, and that's when the card comes in handy, but sometimes it's not available. Sometimes things get rushed and you don't have access to the information. Errors can happen, but we try to be very mindful of if something has a hard stop or contraindication and you don't know anything about the patient, we are as conservative as we can be. Can't not think of that ever happening. And I've been doing this for a little over 10 years. Never heard of a situation like this happening. Is it possible? Not impossible, but it would be very, 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 very rare.
I think the situation that we've heard is of the biggest concern is if someone is intubated, like they have falling blood oxygen levels. They may get supplemental oxygen, but without monitoring blood carbon dioxide. So with FSHD, people can have difficulty expelling carbon dioxide. And so they keep getting more oxygen, which then suppresses the drive
for
we
respiration.
know people have died from that. So that seems like maybe one of the bigger dangers if people don't understand the FSHD in that emergency setting. Do you?
That's a great point. Couple things that we do during the operation, and it really depends on how big the operation is, how long the patient is going to be intubated for. If it's a big trauma where the patient is intubated for a long time, we usually check ABGs, but blood gases, and on those, we're going to have the CO2 level. The anesthesia machine also measures the CO2 level during the procedure. Most of those patients are not extubated in the operating room, depending on how big the trauma is. They're going to go to the ICU, and that's where the monitoring continues. But the CO2 is definitely something that we have to keep in mind. I would say in a place like Mass General, before we extubate a patient, we always make sure that everything looks good in terms of like CO2 level, oxygenation level, respiratory rate, muscle strength for the patients to be extubated. So if we're talking about an emergency and trauma scenario, a patient that went to the operating room, was intubated for a while, so definitely those boxes are checked before the patient is extubated and after extubation. like close monitoring as well to make sure that this is not an issue, especially in a big center in a hospital like this. I've never heard of that happening, but that's certainly something to keep in mind in those scenarios.
Great. Well, this circles back a little bit to other situations. Several questions here about if you were having an endoscopy or a colonoscopy. So, are there particular types of situations there that people should be cautious about, or is it the same for other anesthesia?
Because depending on, like, most endoscopies and colonoscopies are done under what we call sedation, a very deep sedation, meaning that you're still going to be breathing on your own. And we're just going to make you comfortable to tolerate the stimulation from the scopes. Things that we have to be attentive to, the sensitivity to the anesthetic has to be tailored to the patients, like frail patients, patients with muscular dystrophy, especially from the respiratory standpoint, where we don't have like what we call a definitive airway and intubation. We have to be very careful to make sure that you're breathing, your oxygen levels are fine. Sometimes patients can what we call obstruct, and then you have to be very attentive to make sure that you are not obstructing so the air can go in and the CO2 can come out. And the long-acting sedatives that can prolong respiratory rate, like opioids that we usually can give a little bit during the procedure to decrease the stimulation, and sometimes benzodiazepines like midazolam that can prolong the sedation. So those are things that we have to be attentive to, and patients coming in for scopes that require a pretty generous sedation. Definitely be a little more gentle with patients who are sensitive to the medications, like patients with FSHD. And finding a fine balance, because those are very, very, very stimulating. So we want the patients to be very comfortable, obviously, but we also want them to be safe. So we have to strike the right balance between them. And I think that's the main concern on those patients.
Right. We have someone who's asking about, they have a hemidiaphragm paralysis, I guess, so their breathing is impaired. What kind of precautions or pre-op testing should they do for?
Pre-op testing, unless they have any sort of like compromise in terms of oxygenation or respiration or dyspnea, that would be led by a pulmonologist. In terms of things that we are concerned about, certainly certain nerve blocks can cause paralysis of the diaphragm. So oftentimes, usually if it's on the opposite side that does not paralyze, we try to avoid it just so you don't have both sides paralyzed. Because although you're gonna still keep breathing, the sensation of not being able to take a deep breath or not being able to take a deep breath with both diaphragms not working properly is high. So that's one of the things that we are concerned the most, giving you something that will paralyze the other side of your lungs, and that can really compromise your respiratory effort, and that can be a problem, especially post-op. If you're under general anesthesia in the operating room, it would not be a problem because we can help you and breathe for you. After the procedure, that's when it becomes a problem. So we definitely avoid certain blocks, especially for shoulder procedures that can paralyze the diaphragm, what we call interscaling blocks, especially on the opposite side of the injury. And that would be pretty much it. If they need extra support after the surgery, then we can do central spirometry, and non-invasive ventilation or additional oxygen supply until they're fully recovered from the anesthesia. Because there is definitely some hypoventilation after giving all the medicines that we give to keep you comfortable and sleepy until they start wearing off and the patient is fully awake, able to breathe on their own.
Right. Wow. Well, thank you for answering so many questions. There are still many, many more, but we are, I'm afraid, out of time. So
Thank you
you've
for
been
having me.
so generous with your time. We feel very fortunate to have you. And as I said, we'll be posting this information. And if you're able to share the slides or some portion of the slides, we would love to be able to share that with our community as well.
Thank you.
So with that, if you want to stop sharing slides and
Sorry about the
Okay.
slides.
no problem. No, we were able to see it and we'll bring back.
Never seen that happen before. I guess it's like the two monitor issue here, but thank you for
And
having me. I know like people are very curious about anesthesia because it's something that is very, different from everything else. And there are lots of questions, so I'm happy to be able to answer some of them. What I want to say is anesthesia is extremely safe, very, very safe. And we have a lot of tools in the operating room to help us making sure that the patients are asleep, the muscular blockade is reversed, and all those kinds of like little tools to assist us to keep everyone safe, monitored. It's extremely safe to be under an anesthetic with a good anesthesiologist in a good hospital. It's like one of the safest things.
thank you. Well, thank you for keeping it safe and make.
Thank you guys
So
for
I'll bring back Ashley to usher us out and tell us what happens next.
Yes, thank you again, everyone, for joining us. And of course, special thank you to Dr. Castro. We really appreciate this insightful presentation. And of course, you taking the time to answer all of the questions. And of course, we're also grateful to our community for really taking ownership of your health and being here. We really hope that you will consider joining us for our next FSHD University webinar, which will take place on Thursday, March 20th. Our presenter will be physiotherapist I hope I pronounce this right, Ulrike Uta from the Muscular Dystrophy Support Center in Coventry in the United Kingdom, and they will be discussing exercise and physical therapy for FSHD. It promises to be a very interesting topic, as our presenter will also address how to make muscles that are overworking to work less hard and get those that are underworking to work as well as they can given the frame of FSHD. So thank you, everyone. I'd also like to encourage you to visit our website and events calendar for all of our upcoming chapter events, wellness, and education events. And again, thank you for joining us, and we'll see you next month. Have a great day. Bye, everyone.
Everybody, bye.